Today, Mr. Burgett will share with us thoughts on how we can better manage our medical plan spend. Please join me as we welcome Mr. Burgett.
Thank you and good morning. Appreciate the opportunity to talk to you today. Unlike Philip, I'm from Denver, which is only 2 hours time change, but I can tell you it's not the time change that's affecting me this morning. I want to talk to you today. This is kind of moving from global to really local, and talk to you about U.S. healthcare and talk to you about, really the importance of quality. And I think really the need for you as plan sponsors to refocus and identify quality providers and beginning aggressively directing plan members to those quality providers. It seems like the idea and importance of getting good outcomes has been lost. There's a lot of clutter about outcome reporting, about good quality, hospital advertising. I think everyone's quite confused about it. So we really want to identify and direct plan members to qualitative providers. The problem is there are some obstacles in terms of getting to that, some challenges, and I want to talk about those. You know that we purchase healthcare totally differently than any other good and service in the economy. Even with navigators, with transparency organizations, plan members only have the vaguest notion about good quality and outcomes. Most of the information they have is anecdotal. Unfortunately, primary doctors pretty much are in the same place. What information they have is local, it's anecdotal information. At the same time, folks don't have much information on cost. Transparency gives us unit price information possibly, but in terms of episode cost, big cost expenditures, there's really not good information. So major theme here is that there's major variation in cost and quality. If you're going to control the cost of the program, you've got to start identifying those things and driving people to it. So I want to do one slide just as a reminder of the importance of quality. I think we intuitively understand that, but let's address it. A couple of years ago, the Midwest Business Group did a study and verified by others that 30% of medical spend is attributed to poor quality. Just as a reminder, the estimates for 2015, the U.S. healthcare costs are at $3.27 trillion. 30% of that's a trillion. I actually had to Google a trillion to understand what it meant. It's 1,000 billion. Even if this number's off by a large factor, let's say it's only 20%, we're talking about $600 billion in poor quality. Additionally, PricewaterhouseCoopers did a study basically that indicated that for every dollar attributed to poor quality, there's another 50% in lost productivity. So clearly, poor quality is a major driver relative to cost. RAND verified that kind of on the other side of it, but basically saying only 53% of patients are receiving appropriate care. So there's kind of a mess out there, and there's certainly good quality providers, but again, the notion is we've got to go out and identify those. One slide, I think, tells the entire picture. And this is basically, for any of you, this is what you're getting out of your PPOs right now. The vertical axis, this is hip replacements for one of our clients. Vertical axis is episode costs. So you can see costs ranging from $20,000 to about $80,000. Again, these are PPO paid dollars. One administrator, one plan, kind of a regional market. The horizontal axis is a quality score, and I'm going to talk about a quality score. This is using Comparian Analytics. And basically, it's measuring outcomes for major orthopedic surgery and basically bell curving the outcomes from low percentage on the left to high percentage outcomes on the right. But you've got, again, huge variation in cost and quality for hip replacement. This is a major employer in the Midwest. And clearly they're paying the cost for some poor outcomes. So I think it also explains, there are 3,400 hospitals in the U.S. that do joint replacement. So I think even if we're looking at moving folks from the left side of the screen to the right side, from high cost, low quality to the right side, low cost, high quality, the first thing you've got to do is identify who are those low cost people, and then really drive plan members to get to those providers. So the difficulty is that there are some obstacles in getting there. And I want to talk about those probably in some detail. No matter what we're doing in transparency and navigation, and these are certainly the right steps, I believe that plan members are simply overtaxed and not adequately equipped to make the host of healthcare decisions we're asking them to make. Multiple choices that are too complex, plan options, benefit choices, doctor selections, specialist selections, medical decisions. I think we need more interactive support. I call it managed transparency, call it directed navigation, something more that's currently available right now. Second thing I'm going to talk about, huge variation in cost and quality. We're paying a lot for poor outcomes. There's been a lot written about value-based purchasing. You really got to focus on that. Again, it's getting the right return on your investment relative to identifying good providers. Third point is big healthcare. Big healthcare is hospital systems and insurance companies, and they are increasingly oligopolistic. I had to practice that this morning because I wasn't sure I was going to get through that. Few sellers, many buyers, and it's certainly an issue. And again, this is where value-based purchasing has really got to be institutionalized in order to begin getting better value on your spend. So first, let's talk about just on the plan member side and this notion of managed transparency. So again, the myriad choices folks are faced with, as they go through the system. Again, I'm really saying there's just too many things out there. Again, with plan options, choices, choosing specialists, choosing hospitals, and I'm going to show just with some data that I think no matter what, people are always going to be overtaxed. So without a lot of external help, consumers are going to continue to make poor choices. So just for a moment, just consider the requirements. We're thinking about using electronic health information in a high deductible HSA program. What are the needs for information that we're going to have? So again, repeating this, but people are going to have to understand the out-of-pocket expenses relative to their plan options, the tax consequences of those, if they've got savings programs. PCP, primary care choices are pretty easy. As people are considering specialist referrals, hospital selections, more confusing. Understanding and following medical orders and making healthy choices. Again, there's a lot out there, and folks definitely need help in that. You might be familiar with Uwe Reinhardt, Princeton University professor. He does a lot of research in writing in healthcare, and he has a pretty interesting statement, which I'll paraphrase. He's talking about, again, kind of consumerism. The notion of having patients have more skin in the game with higher costs is the same to him as blindfolding shoppers and sending them to the department store and expecting good results. And again, as much information as we're trying, I think we're on the right path with transparency and navigation. I think people are still, overtaxed and really unarmed. So some information, and this depressed me, so it's some reality relative to requisite skills of the population. There's a really good study that shows that, I'll read some of these, so I apologize. 40% of adults have substandard literacy skills. This is in North America, so we're dragging the Canadians down a little bit here. But literacy skills being basically the ability to participate in civil society. So this is, paying taxes, voting, things like that. 40% have substandard skills. The Annals of Emergency Medicine talked about 78% of the patients leaving a hospital without any understanding of the treatment they had. University of Minnesota, 40% to 80% of information patients hear on a consultation is lost. And Health and Human Services, kind of a big point, I think. 12% of adults, only 12% of adults have proficient health literacy. Carnegie Mellon University verified that in a study. Their number was 14% of people, only 14% of people could correctly identify 4 terms: deductible, coinsurance, copay, and out-of-pocket. 14%. So, clearly, guys, I mean, you probably know this, but it's an uphill struggle, and the contention is we need more help. Sorry. So, some steps in terms of my notion of managed transparency, and these are tools that are maybe not available right now, but the view would be to combine health navigation, case management, disease management, second opinion transparency into a highly directed, closely managed model. I'm not Bernie Sanders here, but I really think we need more controls in terms of, again, patients flowing through the system and a lot more assistance. It really is a delivery model that maybe offers very limited choices, probably an HMO-like structure, but we have to get back to where we send in those folks and really the focus on quality. So let's return to the notion of quality for a second. One thing I want to talk about too is when we look at the benefit structure, again, a lot more funneling and incentives relative to how you're structuring those programs I just talked about. So on quality, hopefully we've gotten beyond kind of this 18th century opinion, although there are times when, seems like time is curing everything that we're dealing with. But there is a data set available that should help us in terms of, considering looking at quality. Another one of the charts, this is kind of the same setup as the other one. This is major cardiac surgery in the Denver market. Now, interestingly, Denver is 2.9 million people in the MSA. We have 20 major cardiac programs, which is probably about 14 or 15 too many. And again, the same setup. On the vertical axis, those are Medicare charges in this instance, so it's only the hospital component. And then the horizontal axis is comparing on analytics, again, outcomes, and you can see the wide variation. Interesting thing about heart surgery, recall that one of the outcome risks is mortality. So when those low quality at facilities at the 10th percentile nationally in their outcomes for cardiac surgery, think of the extra risks folks are taking. But again, every PPO, these are all PPO provider hospitals. And again, the reason the hospitals are in the business is obvious because major surgery programs are really significant drivers relative to the bottom line for the institution. The best performing hospital in Denver, interestingly, on the CareChecks comparing data, ranks 90th in the U.S. So the question might be, if your doctor's referring you to the 90th best hospital, what do you think about that? There are 1,100 hospitals in the U.S. performing open heart surgery. Again, probably we only need 300 or 400, but if you're at the 90th, you're really in pretty good shape. It's, again, everything below 500 and going up where, outcomes are really going to be significantly at risk. So talk about Comparian for a second. Is anybody familiar? Has anybody used CareChecks, seen their website? Okay, one. This is a public site. So basically, you can look at CareChecks.com, follow a path, identify the service line you want to look at, identify the state, and it'll show you, talk about how they report their outcomes. So basically, what Comparian does is offer a complete suite of reporting products. They actually started doing work for hospitals and got into the public reporting of data. My opinion, it's probably the most comprehensive tool for measuring hospital quality available today. The methodology combines multiple sources, and I'm going to talk about some of the difficulties with single source outcome reporting. They use 3 years worth of data. They apply scientific measures to that. And one of their principals, a guy named Thane Fortman, actually wrote, believe it or not, wrote 3 books on risk adjusting data. So these guys really are competent relative to measuring outcomes, measuring data. Their clients include academic medical centers, hospitals, where they started out, business coalitions, employers, transparency companies, and others. So for a couple seconds, I'm going to borrow a few of their slides with their permission and talk about their model. So first of all, as you know, there's a number of quality indicators out there. Some of the baseline for these quality indicators are here. The Hospital Quality Alliance reports core measures. Core measures are basically following rules of the road. Does a patient get aspirin when they're admitted to the ER for a heart attack? Does a patient get an antibiotic before surgery? Those are core measures. Hospital Quality Alliance also measures patient satisfaction. The Agency for Hospital Research and Quality, they look at readmissions, procedure volume, and patient safety. Patient safety is wrong site surgery, falls, and drops in the hospital. That's where ARAC focuses. And then, as you know, there's a host of third-party vendors. Healthgrades, everybody's heard of. Healthgrades primarily measures mortality. We've got Consumer Reports, U.S. News and World Report, Leapfrog Group. Leapfrog Group's got great data on hospital outcomes, but hospitals voluntarily report to Leapfrog. So guess what? Good hospitals report, bad hospitals don't report their data. So it's kind of an incomplete data set. But it leads to a lot of confusion, clearly, relative to the information that's out there, and this is all publicly reported. So you can see where folks might get led astray on that. Excuse me. So this kind of creates a dilemma in quality reporting, which is, I guess, obvious when you were using kind of these single measures. So you can have a hospital that has a good core process measures. They're following the rules of the road, except they've got poor outcomes because they've got, a high infection rate coming out of the operating room. Or a hospital that does great in patient safety, but a lot of people are dying because, they don't have a good surgical program. Or they could have good mortality and high complications. I guess you get where I'm going with this. The key is that, and one other thing I forgot is that these single measures also cause some misleading results. So if we're measuring orthopedic mortality, orthopedic surgery really has a low risk of mortality. So if that's a measure, it's kind of an incomplete measure. So what I'm getting to is the need for kind of a complete package, and that's what Comparion's able to do is bundle all services. So they've got the major elements that are necessary, these core process measures that I talked about. They get their outcome data from CMS, the MedPAR file. They get satisfaction and safety scores from HCAHPS. So they measure all hospitals across the country. They're using, again, 3 years of data and cover the complete spectrum relative to outcomes. And then what's interesting is they also break that down within service lines. So, if you've gone to their website, or if you look at their website, you can choose between orthopedic surgery, cardiac surgery, and 36 other subspecialties. And then they're arraying these hospitals in a bell curve. So you've got the high-performing hospitals, the top quartile or the top decile, meaning the ones that you want to get plan members to, and the lower quartile where, we basically want to avoid those. Yes?
Just curious, when you talk about complications, are these adjusting for morbidity as well?
They are. They've got Comparion uses a significant both risk adjustment and morbidity adjustment in their data. And again, it's one of the things that really equalizing that data so all the data basically is looking the same. So that's CareChecks, and again, we use this, we think, as really the best outcome database that's available. So Some strategies for accessing quality, obviously, you can use CareChecks either on their public site. Obviously, you can contract with them and get a very high level of information on hospitals across the country. Obviously, like any problem, if you're working that, identify what the issues are. Looking at where's the spend relative to particular surgery types or disease types. Is it orthopedic and spine surgery where a lot of our clients focus? Younger populations, possibly it's the cesarean section rate for obstetrics. You can direct contract. I want to talk about the provider market in a second, but certainly there are more hospitals interested nowadays in direct contracting if you have concentration in some markets. And clearly, maybe working with navigators and transparency firms in terms of directing folks and maybe more specific direction is definitely in order. So moving on, talking about kind of the health system issues, this is a quote from Karen Ignani. She's the past president of Americans Health Insurance Plans. And Karen here is referring to the provider community and a lot of the merger and acquisitions that have been going on the provider side. Basically, the rhetoric's about efficiency, but the reality is higher prices. If you didn't know what she was talking about, of course, this could be the carrier side as well. Because what's happening right now, obviously, is a lot of merger activity on both sides. And this consolidation really has an impact on, I think, healthcare costs in general. So let's look at that for a second. On the one hand, the carriers. We typically have used a term in the past called BUCAs. The BUCAs to represent Blue Cross, United, Cigna, Humana, and Aetna. Now, recently, the last 6 months, Humana has been acquired by Aetna, Cigna by Anthem, one of the Blue plans. So we're down really to some Blue plans and United and Aetna, so a shrinking market. Same thing happening really on the provider side. Health systems, significant amount of merger activity, hospital acquisitions, interestingly, more clinic acquisitions. Primary doctors, in the past had been acquired by a lot of systems. Now, hospitals and systems are buying specialty practices. Now, this is under, the idea of provider integration. The idea is to increase efficiency. But I think the data we're seeing, some of the reporting that's out there, is that the efficiency may necessarily not be there. A good example of this is Dallas-Fort Worth. If you're familiar with that market, it's really a two-provider market right now. Texas Health Resources on the one side, which is built around Texas Presbyterian Hospital and 24 other smaller hospitals. Baylor Health Systems, the second in the market, merged with Scott & White a couple of years back, has recently joint ventured with Tenet Hospitals. Tenet owns USPI. USPI owns and manages surgical hospitals and surgery centers in Dallas-Fort Worth. So you've really got, again, a two-hospital market. There was a really interesting article in Health Affairs by a guy named Tom Greeny who kind of theorized what happens when these kind of things take place, and you'll understand why I have my figures here. So the two theories that came out of this were first sumo wrestling theory. So sumo wrestler theory applied to healthcare holds that only a large payer can bargain down prices demanded by a dominant or must-have provider. So you need a big to balance a big, basically is what the theory holds. Now, the result, presumably, is when this happens, you as the ultimate payer of this and your self-funded plans are receiving some benefit. We're not sure about that, though. If we look again at Dallas-Fort Worth with Texas Health Resources and Baylor, on the other side of the picture is Texas Blue Cross. Texas Blue Cross is basically a part of Healthcare Services Corporation, which is the second largest Blue plan, and that's a roll-up of Texas, Illinois, New Mexico, Montana, and Oklahoma plans. So you've got, again, the two battling out. Interestingly, healthcare costs in Dallas-Fort Worth are going up substantially. It's one now, after Los Angeles and parts of Florida, probably one of the higher cost markets in the country. The same has taken place in Pittsburgh. University of Pittsburgh Medical Center, there's a lot written about this. On the one side is a provider, Highmark Blue Cross on the other. Highmark a couple of years ago buys out Allegheny Health, the competition for UPMC. In retaliation, UPMC drops all Blue Cross contracts and tries to bring in United Healthcare and Aetna. Has this really created any economies or savings in the Pittsburgh market? No. Costs, again, in that market have risen considerably. So the bottom line is there's no evidence of any reduced cost or positive results with all this activity. Another form of the sumo theory, probably even worse, and, recognizing my graphic may not necessarily reflect sumo wrestlers here, but I guess you get the idea. It's the sumo handshake. And this is basically the big guys decide not to fight. So the studies are showing there's no compelling economic evidence that bilateral monopolies actually produce any better results. The Boston Globe did a study a couple years back looking at private insurance data, and they were looking at payments to Brigham and Women's Hospital, Mass General, and Children's Hospital. They found that those three hospitals were being reimbursed between 50% and 60% higher than their hospital competition in the market. This is where Blue Cross of Massachusetts had cut a favorable deal to get access to high-demand providers. So again, you know, the merger activity, the bigs in healthcare really are not providing any economic benefit. A couple other negatives that come out of this. Again, we talked about the data in terms of improving value, but again, it creates a cycle of merger mania. You know, as the carriers have merged, the health systems are looking to merge and acquire faster. And that basically, from a contracting perspective, creates a lot of problems. There was an article by a fellow named Jesse Colombo titled "The U.S. Healthcare Bubble," and basically talking about the carriers. Insurance companies are turning record profits thanks to brazen rate hikes, as he called it. This is one of the results of scale, as there's fewer sellers out there. The American Medical Association, obviously having their own bias, but American Medical Association also had a study showed that 40% of the markets in the U.S. are dominated by one carrier having more than 50% share in that market. So there's a lot of activity here that's probably going in the wrong direction relative to managing costs or accessing quality. Some other negatives that come out of this, and this is maybe a little more unique, but as these systems have merged, they're also in their contracts basically signing one contract system-wide. And the idea here is that if you want to carve out the high-performing hospital or eliminate the low-performing hospital, you can't do that. You buy Baylor, you buy Texas Health as one. Additionally, and even maybe a more concerning issue is that they're also reporting under one tax ID number. So those 24 hospitals that are a part of Texas Health Resources, you can't identify data on the low-performing hospitals. So down the road, that certainly is going to be more and more of a challenge. And like my graph, you know, here, which is, you know, got great colors, I mean, we really have data, but really it's pretty much unusable data. So a question might be here, you know, in terms of what are options down the road, and certainly there are a couple coming out. You know, the Affordable Care Act basically, you know, created accountable care organizations. Basically, the definition, in case you need that, is entities of doctors and hospitals who come together voluntarily to give and coordinate for high-quality care. Now, we've been down this road really since the mid-'80s. We've had IPAs, individual practice associations of doctors, physician hospital organizations. ACOs are another form of that. Within Medicare, there are two approaches. There's a capitation model and a shared services model. While quality scores are improving, in 2014, Medicare's measure as they lost, after incentivizing the hospitals for good performance, Medicare still lost 2.4 million or 2.6 million, which I agree is a drop in the bucket for Medicare spend, but nonetheless, so far, maybe not getting the results. ACOs are also being structured, and this is maybe the positive side of this. ACOs are being structured for commercial application. You've probably seen that Boeing Corporation is contracting with ACOs in the St. Louis and Charleston, South Carolina markets. So there's an at-risk relationship in that ACO relationship, and we'll have to see how that plays out. So another option that's out there that's gotten a lot of play are private exchanges. And one of the applications a lot of companies have used, Walgreens for one, is basically a defined contribution model. You fix your costs, essentially offer the 3 or 4 options that the private exchange is offering. Your plan members obviously pay the difference based on their selection. Private exchanges have a very cool interface in terms of engagement and also in the enrollment experience. Initial information for 13 and 14 from Hewitt Associates indicated that their 2-year cost increase was 2.6% for their exchange versus the market, which was at 6.5 to 8%. There was an expectation exchanges were going to grow a little more quickly, the private exchanges, that is. It's been a pretty strong employment for the last couple of years, so that's mitigated against that. And additionally, there was an expectation with the Cadillac tax coming out in 2018 that there might be a push toward private exchanges. Now that that's been extended to 2020, potentially maybe a little less interest in the midterm. There's one problem, though, and it's really, I think, a pretty big but. Excuse the expression. We've got the structure, this snazzy high-tech, high-touch private exchange access point, but frankly, it's built on the same system that exists right now. Unless the underlying healthcare system, unless the PPO structures change dramatically, ultimately healthcare costs are going to go up. So even if you're in an exchange on a defined contribution basis, your plan members are going to see increasing costs, unless the system, again, is dramatically changed. And again, with what I've talked about relative to consolidation, that might not be the case unless somebody takes the charge and really starts, directing to quality. Yeah, so some other strategies. In terms of addressing that, I talked about direct contracting, which I think is an option. Clearly, coalitions, can be a good option. Growing number of coalitions from 2 national coalitions to a host of state and regional coalitions got the opportunity for aggregating data and potentially some more leverage in negotiations. Exchanges have not historically done a lot of negotiating, but certainly there's an opportunity for groups of employers to push exchanges in the right directions. I think private exchanges, especially if it's built on, if you find an efficient, accountable care organization, a provider organization that is indeed making some progress and outcomes, that there's an opportunity there for some additional savings. And lastly, there are actually some very innovative third-party administrators out there in the marketplace. One of them is HealthSmart. This is a Dallas-based company. HealthSmart is a roll-up of a large number of third-party administrators. They've done some really innovative stuff on network contracting. Collective Health is a Silicon Valley startup. I think they raised $50 million. So this is a TPA that's got a very high member experience, high touch. They're California-based right now, but expanding outside of California. But I think really a novel and unique approach that could be an alternative to the BUA's administration. And then HealthScope. HealthScope's based in Little Rock, Arkansas. HealthScope's been very innovative relative to population health. So 3 options relative to potentially some of the big carriers for administration. These 3 administrators all are doing very unique things and potentially options for everybody out there. So that concludes the comments for what I had today. So I'd be happy to answer any questions. Yes?
I think is unique about Boeing, I don't know if you
Sure. And that's where coalitions could come in. I think the one thing Boeing has done, though, they've selected specific providers in those markets. So presumably they've done the research on, who's got the good outcomes, who's got the good price points, and are driving folks to that. I think that's one of the right answers out there. Question, yes?
Well, first, one clarification from you is you describe Mass General Hospital and Brigham and Women's as separate, and they are not. So they're both part of partners, and partners contracts through health plans for all of the partners.
Sure, yeah.
So,
Okay.
I'm in Boston, so I just want to clarify that. I think another point in regards to ACOs, and you probably agree, is in many ways, no two are quite the same.
Sure.
And part of why I think some of the more success has been in a lot of the health systems is the infrastructure that needs to be put in place to really manage the risk, to report on the quality, to really drive change under those contracts lends itself more to larger systems. The smaller health systems are really challenged in order to do that. So it's not necessarily a question of more.
It's a good statement. You're right. I think the efficiencies are varying. We saw that with physician hospital organizations. There was never one that was quite the same, and some were successful, some were not. I think it's the problem that we've got in the system, and I think it's the problem that some institutions, based on market location and based on size, as you say, have certainly survived in spite of themselves, in spite of poor outcomes. I think the one important thing I think I forgot, as you're looking at hospitals, look at your local hospital in this CareChecks data, compare them across the board, because hospitals can't be good at everything. I spent 10 years in the hospital business, and hospitals try to portray, hey, we deliver babies, we do surgery, we do all this, but they can't possibly be good at everything. So you can find a great orthopedic hospital that has terrible outcomes in cardiac surgery. So this is, really a need for specialization in contracting and more focus down the road. Yeah.
Well, and probably in a related vein.
Thanks, Julia. In a related vein, you have wide variations in the abilities of physicians as well. You can take a group of orthopedics, and there are orthopedics they are knee guys, but you don't want them doing lower back surgery.
Sure.
And the knee guys do a lot of knees, the hip guys do a lot of hips, and so that a tendon aspect about the surgeon and the hospital setting can have an impact on that variation in quality and outcome.
Yeah, certainly looking for fellowship-trained surgeons who have a very specific focus. Not that they're an orthopedist, but as you said, they're a total joint doctor or they're a hand doctor.
Oh, hi, thanks. Do you have any comments on the consolidation of PBMs or anything going on in the prescription drug area?
Excuse me, I don't, because we don't really play in that space, so I'm honestly really not current there.
All right, thank you.
I've got one other slide, if we have a second, because this is kind of on target, and I think there's some implications. It's kind of complicated, so I apologize. Not that one, this one. This is a study that was published on mortality rates, and the red line is basically looking at white, middle-age Americans between 45 and 54. That's the red line. And this is mortality beginning 1998. Look at that line, how it increased and goes really parallel. So basically, a significant mortality increase in middle-class Americans, even though U.S. Hispanic population followed the same curve as the other countries in terms of mortality decreasing. The theory on this, there was, it was suicide rates, drugs, a number of, societal things. But what's interesting to me is these are the people that have insurance or have had insurance in the U.S. So I'm not sure, this came out in November, and I know there's a number of studies looking at this, but I found this pretty concerning in terms of what is really happening in terms of mortality as an indicator of quality. We've always assumed quality in the U.S. in terms of healthcare was, leading the world, but this is a result that ends up being pretty scary. Yeah, Tom?
Chip, do you have any advice for employers to go back to their TPAs, or their PBMs, or whomever that's supposedly looking out for them, to be able to ask them, probing questions, how are you helping me control my costs for my employees?
I mean, it's in like many discussions the last day or so, you have to start with the data. Are you getting good data, or going outside to get analytics, because you need the information to start. What are the problems you have to address? Then the question is, can that administrator really address them? We all know that the major carriers have centers of excellence programs, but they really don't have steerage mechanisms. They're unwilling to pay one more than the other because they want to keep all those providers in their network. So the steerage, in terms of benefit differentiation, is not really there. That's why maybe some of the more unique and innovative third-party administrators might be an option, because they might be more willing to create mechanisms that are going to provide the answers for what some folks need. Anything else? Thanks very much.
Thanks, Chip.
Appreciate it.